Hello, and welcome to another episode of The Doctor is In. Today we have a special topic. We are talking about women's heart health. My name is Dima Quraini. I'm a cardiology consultant at Cleveland Clinic Abu Dhabi, and I'm director of the Women's Heart Clinic. And I'm pleased to introduce Dr. Batool Abuhalimeh, who is a vascular medicine physician at Cleveland Clinic Abu Dhabi, and she is director of the PERT program as well. Welcome, Batool.
Thank you, Dima. Happy to be here.
Thank you. So, unfortunately, heart disease remains the leading cause of death in women worldwide, including the MENA region and the United Arab Emirates. And that is because we are seeing an increase or very high prevalence of many cardiovascular risk factors. When I think about obesity, diabetes, they're very highly prevalent in the region. Dr. Batool, tell us a little bit about the risk factors that lead to heart disease in women.
That's a very good question. Actually, cardiovascular disease presents really differently in women, and there are different risk factors when we're talking about cardiovascular disease in this population. Mm-hmm. We usually classify them as modifiable and non-modifiable risk factors. But in addition to those risk factors, women do have other risk factors. For example, we tend to see a lot of hypertension in women during pregnancy or during hormonal use. We tend to see more arterial disease in women, such as FMD, which is fibromuscular dysplasia, or SCAD, which stands for spontaneous coronary artery dissection. In addition to that, women do carry different risk factors for hypercoagulable disease. As mentioned, pregnancy, use of hormonal therapy, those things, they do carry like a lot of risk factors for hypercoagulable disease in this population. Mm-hmm. But in addition to the risk factors, what's really unique about female population when it comes to cardiovascular disease mm-hmm. is the symptoms that they usually present with. Dr.
Mm-hmm.
Dima, can you tell me a little bit more about what symptoms would this patient population present with and how different is it from men?
That is an excellent question about symptoms. So there is a lot of misconceptions about how women present with ischemic heart disease. For a long time, people thought that women presented with different symptoms, and they would fault the delays in diagnosis and treatment on the patient. But recent studies have kind of clarified that. So recent studies looking at young patients presenting with ischemic heart disease to the emergency room and to clinic visits have shown that women present like men. They present with chest pain. So the leading complaint when someone is having a heart attack or angina is chest pain. I think the confusion comes from the fact that women tend to present with accompanying symptoms. Mm-hmm. So they are more likely to present with 2 or 3 more symptoms than men. And I think that can sometimes distract caregivers to look for other diagnoses. However, when we look at what patients present with, they do present with chest pain. So yes, briefly, women do present with chest pain. When we talk about what type of chest pain, the classic symptom is a heaviness in the chest. It could be retrosternal or a little bit to the left, radiating to the left arm, and it can be accompanied by shortness of breath, nausea. In elder patients or in diabetics, it can be nonspecific. Sometimes it can be fatigue. They mm-hmm. feel unusually fatigued or unwell.
And I think one of the really important points to mention is that a lot of patients and a lot of female patients, they can't present with those symptoms with traditional risk factors. Like if you looked into their profile, they may have high blood pressure, high blood glucose, family history of cardiovascular disease, and so on and so forth. Mm-hmm. But on the other hand, some patients may present with no typical risk factors, like those patients population that present to us with SCAD and FMD. Mm-hmm. They usually don't have the known risk factors that we know, but they would still present with presentations of coronary artery disease or heart attacks that definitely needs immediate medical attention and medical care. So this is something to point out too.
You bring up a very good point that ischemic heart disease is not one type of disease.
Absolutely, yeah.
You know, when we think about heart disease and heart attacks, a lot of times we used to think of a middle-aged man clutching his chest. Mm-hmm. When he presents to the emergency room, he's urgently taken to the cath lab. We find a blocked artery. Mm-hmm. Done, right? But we know that when women present the same way, even sometimes when you take them to the cath lab, there's still a high percentage that you might not find that blocked artery. And previously, these women were dismissed and told that they have anxiety, they have non-cardiac
They're
cause.
emotional.
Yes, they're emotional. But now we know that they still have heart disease. They still have ischemic heart disease, but it might be due to different pathologies. It could be due to microvascular disease, so disease of the smaller vessels. It could be due to spasm. And in younger patients, as you mentioned, in the absence of traditional risk factors like hypertension, diabetes, they can sometimes have a classic heart attack, but when we take a look at the cardiac cath, we don't see a blockage due to a clot or a plaque, but rather a tear, which brings me to ask you to discuss spontaneous coronary artery dissection with us, because I know that it is highly associated with fibromuscular dysplasia, which is a disease that you specialize in. What have you noticed caring for those patients here in the region?
So, fibromuscular dysplasia is a disease which predominantly occurs in women. It's a vascular disease, affects different vascular beds, more commonly in the kidneys or the blood vessels around the kidneys and the blood vessels in the neck area, but also could occur in the blood vessels around the heart. Now, when it occurs in the blood vessels around the heart, it could lead to what we call SCAD, which stands for spontaneous coronary artery dissection, which usually is a sudden onset, also occurs more commonly in women, and would present like a heart attack kind of symptoms. Although those both disease entities, they remain rare worldwide, we still see a lot of cases every once in a while. Those patients, they don't really have the typical risk factors that you have just mentioned, like the high blood glucose and blood sugar and so on and so forth. However, those risk factors can still occur in this patient's population. One of the things that we do in this patients, if we did notice that they have any of those conditions, is early diagnosis, which means that if we did notice any abnormalities in any of their vascular beds, then this would definitely warrant those patients to have a complete scan, which means that we scan them from head to toe, look into different vascular beds to identify what exact vascular beds are affected with this particular pathology. Based on that, we can direct our treatment. Those patients, they may have symptoms of hypertension, they may have symptoms of recurrent migraines. Some of them may present with stroke-like symptoms or TIAs, and some of them may present with heart attacks. Once we identify this patient's population, we are very keen in making sure that those risk factors that we have discussed are under good control. We do advise them on lifestyle changes, because those patients are at high risk of having dissections or this is the medical term, which means that a tear in the blood vessel. So we do counsel them on lifestyle changes, on appropriate exercise, diet, and appropriate medication, together with very regular follow-up in our clinic. But I do know that we do see those patients together in the vascular clinic, but also in the cardiology women's clinic. So Dr. Dima, tell me a little bit more about what can you offer to women through this very specialized and actually a very unique type of clinic that we have here at CCAD.
Well, thank you, Batool, for summarizing the fibromuscular dysplasia and a lot of the services you offer in your clinic. For the Women's Heart Clinic, so we see a variety of patients. So we can see women with risk factors for heart disease, so women who don't have heart disease. Those are the women we like to see. So when basically they have any risk factor. And actually, 80% of women will have at least one traditional risk factor before the age of 40. So it's very common. So at the Women's Heart Clinic, we see a variety of patients. So we do like to see women with no heart disease, but who are at risk. So these are women who present, like you mentioned, with high blood pressure, diabetes, high cholesterol, or women who've had for example, high blood pressure during their pregnancy, or who've had adverse pregnancy outcomes. We know that these women are at a much higher risk of developing heart disease later in life. So we like to see women who've had hypertensive disorders of pregnancy 3 months, 6 months after their pregnancies, to kind of counsel them and further risk stratify them. I think women underestimate their risk. We know that 80% of women have at least one risk factor by the age of 40, so risk factors are very common. And I think women tend to think of heart disease as something that happens much later in life, something that happens at 60, 70. That is true, but actually recent statistics show that there is a significant increase in heart disease in young women, and there's an increase in mortality in young women. So we like to see these women early so that we can, appropriately risk stratify them and counsel them. We're not eager to start therapy sometimes. The idea is to make sure that they are aware of their risk and that we counsel them on ways they can improve their risk through exercise, diet, lifestyle changes, making sure they don't smoke. So smoking in young women, fortunately, is not very prevalent in this area. However, in women who do smoke, it significantly increases their risk of smoking. It increases their risk of having a heart attack by 7-fold in women under the age of 50. That's one category or one type of patients that we see. But we also see women with heart disease. So these are women, for example, who have ischemic heart disease. We see women with angina, but with no diagnosis, like they've had cardiac CTs or cardiac cath, but there was no diagnosis for their chest pain. So we can offer them further testing to look for microvascular disease. We can also see women who are in their reproductive years who might have pre-existing cardiac conditions or who are at risk of heart disease that we can appropriately counsel and guide them and manage them throughout their pregnancy. So we see a variety of patients, and we're happy to see them, like I said, earlier rather than later.
The points that you mentioned are really amazing. I know that a lot of your patients' population is very complex. And one of the things that I've noticed in your clinic is that it's a very multidisciplinary clinic, which means that you do have multiple specialties that would be helping out if necessary, and you tailor patients' care based on the patient's situation, which again highlights the uniqueness of the service and the clinic that you provide. One of the things that I really want to mention is that a lot of women, as you earlier mentioned, they develop gestational hypertension and preeclampsia or eclampsia during pregnancy, and they think that it's just a pregnancy-related issue, but they don't understand that this is a warning sign. And even though a lot of them, they may develop normal blood pressure after delivery, the vascular changes that occur in those vascular beds, they remain in there. So would you say that this patient's population in particular is a patient's population that you would advise to be seen by a cardiologist?
100%. I couldn't agree more with you. I think pregnancy used to be thought of as a stress test.
Yeah.
I think it's more than that. I really think it's a window into a woman's future cardiac health. At the heart of a pregnancy, we're dealing with the placenta, which is a vascular organ. So I think, we don't understand the pathophysiological link 100% between hypertensive disorders of pregnancy and heart disease later on, but we know there is a strong link. And whether it is because these women carry a lot of the traditional risk factors or whether there is something that is initiated during the pregnancy, we know that something biologically changed and that these women are at a higher risk. So to me, when I hear that a woman has had a history of hypertensive disorders of pregnancy, whether it's just gestational hypertension, so high blood pressure during pregnancy, or preeclampsia, those are red flags. So these women should never be reassured upon their delivery. Even if their blood pressure, as you mentioned, normalizes, they're still at a higher risk of developing high blood pressure and heart disease. So actually in recent European and American guidelines, they do recommend that these women be evaluated by a cardiologist within 6 months. And we do have a hypertensive disorder program within our women's heart clinic where we like to see these patients within 6 months post-delivery to kind of, again, readdress their blood pressure, but also look at their whole cardiovascular risk, and advise them.
That's really amazing. That's really wonderful. So besides pregnancy, a woman passes through different hormonal changes all through her life. One of them is menopause and pregnancy, and also like when women decide they want to start any hormonal treatment or oral contraception pills. One of the things I've noticed from my particular practice is the risk of hypercoagulable disease in those patients. And I know in our vascular clinic, and I'm pretty sure that it's the same in the cardiology clinic, a lot of counseling is usually provided to female patients before they start oral contraception pills, especially if they do have history of risk factors that exposes them to hypercoagulable disease like migraines, family history of blood clots, or prior history of blood clots. The other thing is women that develop hypercoagulable disease during pregnancy. Usually those female population would be extremely stressed out when attempting to expand their family further, because they would be concerned that they may develop another blood clot compared to their previous pregnancy. And this is where we actually also hop in and help and manage the patients during pregnancy. And I feel like there is a lot of lack of awareness when it comes to women's cardiovascular health in general, whether it's during pregnancy, menopause, when taking any hormonal therapy. Dr. Dima, what kind of advice would you want women listening to us to know when it comes to their cardiovascular health?
I would like women to know their numbers, is what I say. It's know your numbers, know your risks. So the first step is to be aware of your blood pressure, your blood sugar, your cholesterol numbers, your weight, obviously, so the first part is knowing those numbers, and then working on your lifestyle. So there's recent data that shows that women actually benefit more from exercise than men. So there's actually a study that looked at all-cause mortality and the number of minutes of exercise a man and a woman performed during the week. And women derived a higher mortality benefit than men when it comes to exercise. And yet, research shows us that women are less likely to reach the recommended goal of exercise per week. So I really spend a lot of time in clinic counseling our patients about a healthy lifestyle, about pursuing aerobic exercise, but also including isometric exercises, especially after the age of 40. I counsel patients about their diet, about consuming a heart-healthy diet, rich in a lot of vegetables and fruit, staying away from processed food, animal products. So a lot of it is based on counseling. Prevention plays a big part in heart disease. Dr. Batool, you mentioned fibromuscular dysplasia, you mentioned hypercoagulable states. Tell us a little bit more about what type of patients you see in your vascular clinic. What are the other services you can offer in your clinic?
Thank you, Dima. That's actually a great question. So in our vascular clinic, we look into vascular health in general. I usually like to say that we look beyond the heart. In the clinic, we do see patients with a lot of complex different medical conditions, as you mentioned, arterial condition like fibromuscular dysplasias, and patients who have different type of vasculitis. We do see patients with hypercoagulable disease, especially those that develop hypercoagulable disease during their pregnancy, which could be because of the pregnancy state itself, since it's considered a hypercoagulable state, but sometimes it could be because of other conditions like May-Thurner condition, which is a condition due to an anatomical abnormality that increases the chances of having hypercoagulable disease. We do manage hypercoagulable disease and blood clots during pregnancy and during the postpartum period and during the breastfeeding period. But I also see a lot of women having varicose veins. Many women develop varicose veins during pregnancy. It can cause a lot of discomfort, swelling, pain for those women. Unfortunately, surgical treatment of varicose veins during pregnancy is not favorable because it carries a lot of risk factors. So we usually do a conservative management for those patients during pregnancy, and then we make sure to follow up with them after pregnancy and after breastfeeding to ensure that they get the most appropriate treatment or management modality. So in short, we do see a variety of complex vascular conditions, in men and women, but a lot in women. And I feel like the vascular clinic that we do have at CCAD, a lot of my female patients describe it as the safe zone, because they love coming to the clinic, telling me about their signs and symptoms, and they know that they do have someone who's going to listen to them and help them in any way possible. We do see a lot of women that are close to menopause or are already passing through menopause, and they're developing some symptoms. And we do collaborate with the menopause clinic that we have here at CCAD, which has been very helpful. A lot of expert physicians that have been very helpful in taking care of our patients and helping them through the symptoms. And we do collaborate also with the cardiology clinic and with you. So we have a lot of shared patients. So I feel like having those kind of clinics that would help focus and address on female or women's health has been very helpful for the women's population, because they can find a place where they can get the help that they need, and they can find the experts that really do understand their bodies, they do understand their hormonal changes and their needs in a very specialized manner.
Well said, well said. You brought up the question or the topic of menopause, and I think it's like really there's been a revived interest in menopause these days. For the longest time, we were not prescribing hormone replacement therapy because of the concern of increased stroke and cardiovascular events. What are your thoughts about the risk of stroke in those patients? Are you seeing more patients being referred because of menopause and the concern of stroke risk, DVT risk with HRT?
Absolutely. So I think now we have a better understanding of this topic. We have more data, understanding why would those patients develop cardiovascular events in setting of the use of hormonal therapy. Of course, we're extremely cautious with patients that have history of DVTs or strokes when we want to start them on hormonal replacement therapy, but we do weight risks and benefits. We do have alternatives to oral supplements that can be used. So what's really nice about what we know right now is that we tailor patients' prescriptions, or what we actually do give patients based on patients' symptoms and patients' needs. So we see exactly what is the patient passing through, what are her needs, what are the things that are bothering her at this stage of her life, and we address it accordingly in a very safe and medical manner.
Exactly. I think even from a cardiac standpoint, HRT has changed. There's a lower risk profile with the current therapy, the transdermal patches, the current hormones that are being used. And there's also been more studies that show maybe that risk of stroke and even ischemic heart disease might be lower. Now, it is important, I think, for our patients to understand that we never prescribe HRT to prevent heart disease or to treat heart disease, but that in low-risk patients, so patients that have just had or have just transitioned into menopause in the past 5 to 10 years, or in women with overall low risk, or in women in whom we've optimized their cardiovascular risk, in those patients, it might be safe to use HRT. But like you said, I think more and more now we're moving into treating patients as a team rather than making the individual decision by ourselves.
Absolutely.
We try to incorporate our other services, like our colleagues in the menopause clinic as well. So we talked a little bit about how we treat our female patients. I think in cardiology and in vascular medicine, what we're seeing is that it took us many years to learn how women present differently than men. I think over the past years, we've learned a lot about what is different in women than in men and where our similarities lie. But I think it took us a long time to get there because women were often underrepresented in trials. Women were not studied, and we were always just assumed to be similar to men. But we now know that there are differences. Disease might present differently in women. Even the response to therapy, we might be over-treating women. For example, when I think of heart failure, we think that women might actually respond at lower doses, which brings up the question of the need to study women. What are your thoughts about that? How can we increase women participation in trials? How can we increase the number of trials looking at women? What are your thoughts on that, Dr. Batool?
So I think that's a great point that you mentioned. There is a lot of studies where women have been underrepresented, especially when we're talking about vascular disease. But recently, this is definitely changing. So a lot of studies are looking into having a more similar population between women and men, just to have a better representation of females in those studies. Because as you mentioned, we do know that vascular and cardiac disease presents differently in both parties, and also the response for whatever management and treatment we're going to implement in those two genders is different. I think that most women, when it comes to clinical trials, they either do not participate for cultural reasons or out of fear, because a lot of those women, they don't really understand the significance of their participation in those clinical trials and how much they would be contributing to our understanding of different pathologies, but also contributing to the help that they could provide for the future generation of females who may need those medical therapies or who may face such pathologies that need diagnosis and treatment eventually. But what I could see right now is that a lot of this is practically changing. A lot of women nowadays, they are advocating for their own health and for other women's health and other females' health. Females are really trying to understand their health better. They're trying to focus on the preventive manner of multiple diseases and comorbidities, as you mentioned, is one of the most important points that you're doing in your clinic, because preventive medicine is practically the key.
Absolutely.
As long as we prevent those conditions, we just don't have to deal with the complications or the problems that could be as a result of that. So 100%. I think this is where a lot of females are practically keeping themselves from being a part of those clinical trials, but this is definitely changing nowadays.
I think as we see more female investigators as
exactly.
well,
That's a very
they
good
tend
point.
to focus on recruiting or ensuring that there are
Absolutely.
sufficient female representation in the trials. We talked about risk factors earlier. We talked about hypertension. I do want to talk a little bit about hyperlipidemia, because what struck me when I started working in the region was the amount of misinformation there is on lipids and the amount of skepticism when it comes to starting therapy, especially statins. I find there's a lot of concern and fear. And I'm not really sure where all of that came from. I don't know if you experienced the same thing. So I'm surprised by it, because obviously there's a lot of literature and a lot of research that supports the link between lipids, especially bad cholesterol, and heart disease. And recently there's been also, we've been measuring a new biomarker, lipoprotein a, but I still find a lot of struggle in initiating therapy in patients. How do you think we can change that? How do you think we can educate our patients about the role of lipids and try to kind of overcome the fear of therapy?
Absolutely. The points that you mentioned are very significant, Dima, because when I moved to this region, I also noticed this a lot. I think, as you mentioned, educating patients, that's the key. So when I see those patients in my clinic, and I do know that they need to get started on lipid-lowering agents, the first thing I do is counsel them extensively, explain to them, why do they need this medication? What exactly does this medication do? I'm usually very clear about the complications that this medication is carrying, together with the benefits. Just to explain to them that although those medications does have some complications or side effects, the benefits overweigh the side effects. And this is why I would recommend that you would use this medication, evidence-based medicine. So I do share with my patients what is the most recent data and literature on this topic, so that they would exactly know where is this coming from. But one really important point that I would mention to you is a lot of those patients, when I would ask them about where does this come from, like their beliefs about hyperlipidemia and statin therapy and everything, the answer is always social media. And that's why I'm also very keen on like counseling the patients on the importance of being very careful when it comes to social media. Don't believe everything and anything you hear in there.
Thank you, Dr. Batool. Those are excellent points. I think there's a lot of misinformation from social media out there. It is always important to educate our patients. And even diet, we talk about before lipid-lowering therapy, there's a lot of room to improve in the diet. I think, we have to focus on reducing animal fat. There's a big consumption of animal fat in the region and ultra-processed foods that not only increases the risk of high cholesterol, but high blood pressure and blood sugar. How do you counsel your patients? What are your advice, or what would be the key messages that you would like to communicate to your patients today?
I would actually really like to tell female patients to not neglect their health, because this is something that it's very much noticed within a lot of women. No matter how busy life is, no matter how much responsibilities you have, your health should always be a priority. You should always take care of yourself to be able to take care of people that you love and people around you. The other thing is, if you do have any family history of any cardiovascular disease, please make sure to check up with a doctor, because preventive medicine is always the key. And if you did develop any kind of cardiovascular disease during pregnancy, make sure to follow up with your physician and also with a cardiovascular physician after pregnancy to ensure that you're doing well and to prevent you from having any complications moving forward. The last thing that I would say, hormonal therapy is necessary in a lot of situations, but don't get yourself started on hormonal therapy without appropriate counseling, without seeing a physician. Even if we're only talking about oral contraception pills, they still carry risk factors. So you need to see someone and get appropriate counseling before getting started on those medication.
Those are excellent points, Dr. Batool. And with that, we would like to conclude our session on women's heart health. If you have any further questions, or if you have risk factors, or if you recognized yourself in any of those topics we talked about, please feel free to contact us and make an appointment at the Women's Heart Clinic or the Vascular Clinic. We'd be more than happy to discuss this further with you. Thank you.